Welcome everyone. It's just gone 1 o'clock, so we'll start on time. I'm Matthew. I'm a GP and Professor of Primary Care at the University of Bristol and the Chief Investigator on the ATHENA trial. And welcome to our talk about shingles. I'd like to introduce my colleague, Bob Johnson.
Hello, I'm Robert Johnson, Emeritus Consultant in Pain Medicine at the Bristol Royal Infirmary and a Senior Research Fellow in the University of Bristol. I've had the good fortune to work with post-herpetic neuralgia patients clinically and for research since 1973.
So thank you very much for taking the time to join us today. We're going to record this, so if you miss anything and want to watch it back or would like to share it with your friends, we'll make it available widely afterwards. You should be able to see the slides, as I say, on the screen. And if not, do just pop a message in the chat and we'll try and address any technical issues. Otherwise, as advertised, the talk's going to talk about shingles, where it comes from, why we get it, how we should think about treating it, what are the potential complications of that, and why the ATHENA trial is so relevant to that particular issue. So I'll hand over to Bob, who'll do the first part of the talk, then I'll come back in a bit later on.
Thank you, Matt. I think it will be helpful if we first remind ourselves about herpes zoster and its cause before we discuss epidemiology, complications, treatment, and prevention. First of all, why are herpes zoster and shingles so named? Well, herpes is Greek for creeping, I guess the creeping progression of the rash. Zoster is Greek for a belt that supports a soldier's shield, rather shaped like a thoracic dermatome. And the French call it zona, which is just the female equivalent of zoster. And shingles comes from the Latin singulus for a girdle. The varicella zoster virus, which you can see at the top of the slide in a schematic sort of diagram, it shows a capsulated double-stranded DNA alpha herpes virus with surface glycoproteins. The latter has some relevance when we talk about vaccines a bit later. So what do those terms mean? Well, the alpha herpes viruses are varicella zoster virus and herpes simplex virus types 1 and 2, and they are neurotropic. The meaning of the latency and the translocation of virus around the body are within nerve tissue, apart from the very transient viremia that's associated with varicella. All herpes viruses have the property of causing a primary infection followed by clinical latency and reactivation to cause a secondary disease. In the case of varicella zoster virus, the primary infection is varicella, the little child on the left, and then there is latency, usually for a long period of time, and the secondary disease on the right, herpes zoster. The upper picture is of a typical dermatomal thoracic zoster, and the lower one a rather horrendous herpes zoster ophthalmicus. Seropositivity testing shows the presence or absence of VZV antibodies. It's an easy laboratory test and indicates prior infection with varicella zoster virus. In other words, the individual has had varicella in the past. These curves with percentage of the population on the y-axis and age on the x-axis clearly show that in temperate climate regions of the world, almost all the population is seropositive by about 15 years of age and therefore at risk of developing zoster at some stage during their lifetime. And the lifetime risk is actually 30 to 50%, depending on longevity. As varicella tends to occur at a greater age in tropical climates, young adults migrating from such countries may not be seropositive. An example is nurses from the Philippines who frequently work in care homes in the UK with older adult patients who might develop shingles, and their carers may then contract varicella from them. So it's wise to test the serostatus of immigrant nurses from hot climates and to offer them quite enthusiastically varicella vaccine to protect them from the risk of developing chickenpox. Who gets zoster? Well, far and away the most common cause of zoster is immunosenescence. Varicella zoster virus specific T cells are reduced both in number and competency as a normal part of aging, although the rate of this decline varies between individuals. As a rough guide, about 10% of cases of zoster are in immunocompromised individuals, and these people have about 10 times the risk of zoster, if that isn't confusing, but it varies widely according to the cause of immune compromise, malignancy and its treatment, immunocompromising disease, and therapeutic immune suppression. Leukemias and lymphomas, HIV, and therapeutic immunosuppression following organ transplant are at the high end for risk of zoster. Solid tumors and moderate doses of steroids are at the lower end. In younger people, particularly with more severe zoster, it's just wise to consider possible causes, lymphoma, leukemia, HIV, etc. However, in the vast majority of cases, it will not have a sinister cause. How common is zoster? This slide shows data from the UK and the Netherlands. The UK data in blue is from Edgar Hope Simpson's seminal work. He was a GP in Cirencester, still working on the subject of herpes zoster and its epidemiology until his death a few years ago, aged about 92. The incidence of zoster, the curves on the graph, and the right-hand vertical scale over all ages averages about 3.4 per thousand of the population per year. But from about the age of 50, incidence rises sharply, reaching about 11 per thousand per year for the over 80s. The absolute number of cases, the vertical bars and the left axis scale, depends on the proportion of each age group in the population. So the peak in terms of numbers of cases comes between 50 and 70 years of age. Firstly, one cannot assume that a low pain level during the first few days of zoster guarantees that the pain will not get worse. It's also useful to note whether or not the patient has allodynia, that intense pain from very light, normally non-noxious touch. And if that is a feature, then advice on wearing loose cotton clothing, and sometimes a useful tip is to put a little piece of cling film over the very sensitive area, which just offers protection. Oral antivirals are effective in relieving acute zoster pain, hastening rash healing and shortening the duration of viral shedding infectivity. They have not been shown to reduce the incidence of post-herpetic neuralgia, even with the addition of steroids. Topical antivirals have no place in the management of cutaneous zoster. Surprisingly, there are no studies of paracetamol versus non-steroidal anti-inflammatory drugs for acute zoster pain, but clinical impression is that the former, paracetamol, is more effective. If required, the addition of codeine, the 3500 compound, often helps, and in the short term, tramadol can be used and may be effective. There is no evidence that amitriptyline reduces acute zoster pain, as opposed to possibly, as Matt will talk about later, preventing post-herpetic neuralgia. Topical applications are often unnecessary, and avoidance of buildup of messy potions is advisable. Return to pre-zoster levels of social and physical activities as soon as possible after zoster is to be encouraged, and I'll refer to that a little bit later. Far and away the most important risk factor for post-herpetic neuralgia is greater age, but female sex, prodromal pain, greater acute pain and rash, as well as immune compromise, are also significant. Diagnosis is usually clinical, but if confirmation is necessary, PCR, polymerase chain reaction of the vesical fluid, which has is a test with high sensitivity and specificity, and it's the test of choice. The most common misdiagnosis is herpes simplex types 1 and 2, labial and genital. Herpes zoster recurrence is rare. Herpes simplex recurrence is common. Herpes zoster recurrences occur in the literature in up to 5% of immunocompetent patients, although recent data from very large data sets internationally suggests the incidence of second cases is less than 3%. However, recurrence is more common in immunocompromised patients. Herpes simplex occurs in all age groups, whereas herpes zoster is much more common in older adults. Take note of dermathermal pattern for herpes zoster and the typical patches of lesions around the mouth, buttocks, the genitalia for herpes simplex virus, but the lesions themselves do appear remarkably similar. Possible complications are numerous, but post-herpetic neuralgia, PHN, is by far the most common. Others may be serious and should be considered, and I will mention just two. Herpes zoster ophthalmicus, we saw a picture on the first slide, may affect the eye as well as the lids if the nasociliary nerve is involved. This may also result in a positive Hutchinson sign, which is herpes zoster rash on the tip of the nose and the adjacent alar of the nose. If this is present, the eye should receive specialist examination because the uveitis, even retinal necrosis, can be disastrous. Far less common, but important, is that incidence of vasculitic stroke within a 6 to 12 month period after zoster is increased. The greatest risk is during the first 4 months and in patients, interestingly, below the age of 45. Most commonly, this follows herpes zoster ophthalmicus, but not exclusively. Here we see the prevalence of pain by time in zoster. So we have the proportion of patients with pain on the y-axis and the time in months after rash appearance on the x-axis. And the colored bars denote that the pain is less than a score of 3 on a 0 to 10 scale in the blue columns, severe pain, 7 or greater in the yellow columns, and clinically significant pain, which I'll come back to, scoring 3 or more in the red columns, and during 48 months following the start of herpes zoster in a large cohort, 566 patients in the Netherlands. Pain scoring 3 and above and 90 days or longer following rash appearance is termed post-herpetic neuralgia. This definition is chosen because a score of 3 and above on a 0 to 10 pain scale has been shown to cause significant and problematic reduction in activities of daily living and quality of life, and is thus referred to as clinically significant pain. And the graph clearly shows that there's a rapid reduction in the proportion of patients with pain up to 3 months, the start of post-herpetic neuralgia, but from then on, improvement is slow, with some patients still having pain of all of the 3 grades of severity at 4 years after zoster. Duration of pain is directly related to greater age. This slide includes all pain of any severity, hence the rather high incidence of pain at all time intervals. It's not just post-herpetic neuralgia. The y-axis denotes the percentage of patients with pain, the x-axis the time up to 6 months. The key for the curves is below the graph, and the upper curves represent the older patients, and the lower curves represent younger patients. Treatment. Well, drugs most commonly used for treatment of post-herpetic neuralgia other than simple analgesics are tricyclics, usually amitriptyline, gabapentinoids, gabapentin and pregabalin, and strong opioids, morphine, oxycodone. The number needed to treat for any given drug is the number of patients receiving medication who gain 50% reduction in pain compared with those taking placebo. And to match that is a number needed to harm, which is the number of patients receiving medication who suffer significant side effects compared with placebo. To summarize, medications used to treat neuropathic pain, which post-herpetic neuralgia is an example, offer only modest benefit and may be accompanied by significant side effects, particularly in older adults who may be taking concomitant medication. Less than 50% of PHN patients gain as much as 50% pain relief from oral medication, with similar figures for side effects. Topical lidocaine patches may offer complementary benefits, and there are many other treatments that are proposed, but there's really no satisfactory evidence for their benefit, or it should be said otherwise in some cases. We're all well aware of the risks of strong opioid use in chronic pain, and by coincidence, new guidelines were published by the CDC in the United States just 2 weeks ago. And I put the reference there in case you might want to refer to them. They are actually very nicely composed, and I think we can be very grateful to the CDC for doing it. Frailty increases with age, as you know. The next two slides were produced by my colleague Thomas Reinke in Potsdam. The x-axis is age, the y-axis represents functional status for male and female, the two different colored curves. Self-efficacy and activities of daily living occur as a result of aging, as we all know, and we've got normal curves there. Acute zoster, the light blue curve, hastens decline significantly. But the point of this slide is that many patients do not return to the curve that they should be on when their shingles begins to recover and may suffer a long-term deficit. This is why I emphasized earlier that encouragement to return to pre-zoster or better social and physical activities is important and may well prevent longer-term loss of self-competency and independence. Prevention of zoster. Well, we have two vaccines for protection against herpes zoster and post-herpetic neuralgia. Live attenuated Zostavax, which is the left-hand column, and the recombinant adjuvanted subunit, and that's why I mentioned these little glycoproteins on the surface, and in this case, glycoprotein E vaccine Shingrix on the right. The NHS zoster vaccine program that we've all been involved with currently uses Zostavax, the live attenuated vaccine, except for certain groups of immunocompromised patients when Shingrix may be used. And this edition is, I think, quite recent. My personal view is that the age group offered vaccine, 70 to 79 years, is too high, and no boosters are offered, despite the fact there's relatively short durability of protection offered by Zostavax, 4 and a bit years maybe. Durability for prevention of PHN, however, with Zostavax is rather better than for zoster itself, just showing that it attenuates the disease, so we get a milder case of zoster. I suggest that the current program is a good starting point, but should in time be replaced by the recombinant vaccine Shingrix with its much greater efficacy, 97% odd, and it is preserved at that level into old age, pretty well that level anyway. And it already has been shown to have a 10-year durability, so it is much longer acting. However, Shingrix The recombinant vaccine requires 2 injections and is more reactogenic than Zostavax. But perhaps patients are now more accepting of this because of their experience with COVID vaccines. Vaccination will never prevent all cases of Zoster, and thus there will always exist cases of PHN. At present, we have no proven means of preventing PHN other than preventing Zoster. Antiviral drugs are very effective in reducing severity of acute pain and rash, as well as other complications, but do not prevent PHN. Thank you.
Thank you, Bob. So that's a really nice summary of what we know about shingles and prevention of complications. And we also have demonstrated that wouldn't it be nice to prevent the most common complication of post-herpetic neuralgia rather than just treat it. And as Bob has very nicely summarised, the only thing that really seems to work in that area is vaccination. Various other things have been tried. Surprisingly, antivirals that can help in the acute phase don't prevent pain later down the line, and neither do other interventions, other drugs such as gabapentin or corticosteroids. The possible exception to this might be amitriptyline, but this is based on a study that was published as a single author paper. And if you take the time to go back and look at the paper, it's not very well described, but essentially Bauscher recruited 80 patients over 6 years of age and randomized them in a clinical trial to receive amitriptyline or placebo. And according to his results, he demonstrated a 45% reduction in the prevalence of pain at 90 days. So that's very interesting, given there's also a plausible biological mechanism for this. There's some evidence that amitriptyline might bind to the nerve growth factor receptors and thereby prevent nerve damage. But as I say, the study isn't very well described or reported, and it's never been replicated. So this is where we've come in. The NIHR, which, as you probably know, is the research arm of the NHS, has funded us, so myself, colleagues in Bristol, Southampton, and Oxford, to answer the research question of whether taking amitriptyline as a preventative prophylactically prevents pain later down the line. And we're seeking to recruit adults over 50, because that's where most shingles is. Within 6 days of the rash, the idea we want to get the treatment to them as soon as possible in case that time window is important. And obviously we want people who are able to take the medication, though of course, because it's a trial, placebo trial, neither they or us will know whether they're taking amitriptyline, because that's the only way to do a fair test. We've tried to make this as simple as possible. We're recruiting through GP surgeries, over 150 at the last count. And this little flow chart, you may not be able to see the detail of the text, but essentially it shows that the top half is where the GPs are involved in identifying and approaching patients with shingles who are potentially eligible and signposting them to the study. And we asked them to do this just by means of a very simple crib sheet that just introduces the study to them with a summary information sheet. They then complete an online form, which passes the details with the patient's permissions onto us. And thereafter, we as the research team do all the work in terms of consenting and collecting the data. And we randomize them to either, as I say, an active treatment, amitriptyline or placebo medication. We get that to them as soon as possible. We ask patients to up titrate, to take 1, 2, then 3 tablets if they're able to over the first 2 weeks. But if they can't tolerate 3 or 2, then 1 is absolutely fine. This is a pragmatic trial reflecting what will actually happen in clinical practice if we find this is a useful treatment. And we follow these people up for a year in total, mostly through online questionnaires, but paper questionnaires for those who prefer it. And our focus is at this 90-day time point when we're going to measure the presence or absence of pain and see whether amitriptyline has any effect on how common that pain is at 90 days. How are we doing so far? Well, thanks to an immense amount of work on behalf of the team that helped me deliver this trial, we've managed, and our GP colleagues, of course, we've screened over 500 patients, of which 200 were referred as potentially eligible. And at last look, we were up to 140 randomized patients. Our oldest participant, I'm pleased to say, is 92 years. That's really important because of the association with more troublesome pain with age, and because we want this to be as inclusive as possible. And I'm really pleased to report that those that have taken part stay part. They don't have to, but people are happy to stay part of the trial once they do so. And the majority of people are able to take the medication for that first 70 days. And the graph there just shows how, since our recruitment started in April, both the number of patients screened, referred and randomized has increased. However, we still need more patients and more GP surgery. So if you have taken part in the study yourself or your GP supporting the study, thank you very much. But if you know someone with shingles, or you've got a GP colleague who might be interested, do put them in the direction of our study website. And if you have a friend or relative or someone who develops shingles, have a look on the website and you can see through there whether your local GP surgery is taking part, in which case do put yourself forward, because it's only with everyone's hard work we will be able to answer this important question and find a treatment that might prevent pain later down the line, because as Bob's very nicely summarised, we don't have any options really other than to treat pain at the moment for the people who get it. So we're coming towards the end of the time here. I think Helen's going to slightly pop the slides down. This is an opportunity for you to raise your hand or pop questions in the chat if you'd like to. If there's anything that we've gone over a bit quickly you would like to clarify, now's your chance. I'm very happy to talk through the trial and what's involved, and Bob's a bit of an expert on the topic, so pop your questions forward. If not, that's absolutely fine. We may well have answered all your questions already. I'll just give you a few minutes because sometimes it can take a little while to pop a question in the chat. Okay, thank you. See a question there from Monica, the dose of amitriptyline. So I didn't talk a lot about amitriptyline. So this is a tablet that's been around for decades. It's used mostly at low dose now for a range of conditions. For example, I've been recently involved in a study looking at its use in irritable bowel syndrome. So the dose we're using in this study is similar to what was used in the study that I talked about in the late 1990s, where participants are asked to take 1, 2 or 3 tablets, and they're 10 milligram tablets. So the maximum dose anyone has taken is 30 milligrams. It is used in some conditions up to 50 milligrams, and traditionally was used at much higher doses. The advantage, obviously, of using lower doses, people are less likely to get problems with it. Is there any other questions? Okay. Well, we're coming up to 1:30. Is there anything you wanted to add, Bob, before we let people get on with their day?
No, I don't think so, except to encourage interest in herpes zoster and really encourage patients to get back to normal activities as quickly as possible. I sincerely believe that is a very important part of rehabilitation.
Okay, great. Thank you very much for everyone for joining us. We will put the recording on the website if you'd like to signpost your friends to it or watch it back. Yeah, really appreciate your interest in our study. And thank you very much to Bob for taking the time to do this with me today.